right, any more questions before we switch gears and talk about real things that happen to live tissues and are responded to? Much more exciting. Okay. All right, so moving on to things that accumulate within cells and tissues, we have a whole menu of these. Some of them are just normal metabolites, normal cell components that are, there's too much, so either we're producing too much and we're not getting rid of them, or some other thing is happening, but they're normal things, we just have too much of them accumulating in the cell. We can also have accumulation of abnormal things. So exo means from outside. So these are things that are coming from outside the body. Minerals can build up. You guys have heard of lead toxicity. You know, some of you watch CSI, so you've seen the lead, and you know it causes inclusions in tissues. Those are accumulations of lead inside of cells. You can also have endogenous. So the attack can come from within. Call can be coming from inside the house. You can have abnormal synthesis, so you can be making too much of something, or you can be not able to, sorry you guys, my words there bad. Maybe you're making an abnormal product. So maybe you have, you know, an enzyme or a protein that's defective and it's making this substance that is usually able to be broken down, but now because it's modified, the body can't break it down. So it's just going to build up. The body is going to basically put it in a closet or under the rug and be like, we're just going to ignore that. And at some point it starts building up in the cell and causing problems. The cell can't ignore it anymore. You can also have pigments. These can be exogenous or endogenous. Most of them are pretty inert. They just kind of sit there. So a couple different broad overview mechanisms of accumulation for this kind of stuff. You can be producing normal amounts of a normal substance, but your metabolism is altered. So you're not able to metabolize the full amount. So lipid is a good example of this. Anybody worked in a clinic and had a anorexic cat, a fat anorexic cat? That is an emergency, right? Because do we know why? Yet? The liver? Yeah, so if a cat stops eating, the body starts to metabolize fat so the animal doesn't starve, but the animal is so fat and the body is metabolizing so much at once that the liver basically gets clogged and it's like, whoa, that's too much fat, I can't. And so fat starts accumulating. That causes damage to the liver cells. Cat goes into liver failure, cat dies. Long story short. So that's normal production of a normal substance, but maybe there's too much of it coming in, our metabolism is messed up, we're not able to clear it in the way that we normally would. Another category is abnormal production. So these are mostly genetic defects. Some of them can be acquired, some of them, there are some toxic plants that mimic lysosomal storage diseases because they interrupt some of these metabolism pathways or production pathways. So these are often proteins or lysosomal storage components, but the body is producing something that's either it's supposed to make it, but not in this form, or it's not supposed to make this thing at all. And so the body can't handle it, it accumulates because it doesn't have an enzyme to break it down. You could also have a defect in the enzyme that breaks this normal thing down. That would lead it to accumulate. And then the third category is kind of these inert pigments. They don't do anything. They don't really cause a lot of damage to the body unless they're in like massive amounts. It's just that the body can't metabolize it. We don't have an enzyme to break down silica because we are carbon-based life forms. Although we don't have a mechanism to break down carbon either, so I don't know what our excuse is there. But these are just inert things. They don't really trigger a big immune response. We can't deal with them, so they just kind of build up. And then important point for pathology and noticing lesions, the accumulation is usually going to occur where the thing is being produced or metabolized. So for example, we think about a cat with lipidosis. The liver is the primary site of lipid metabolism. So that's going to be the primary site of lipid accumulation when you have some kind of lipid disorder in a lot of cases, right? Okay. Lipidosis. Left off talking about accumulation in cells. So remember, osis is a specific condition. Lipidosis is the condition of too much lipid accumulating in your cells. Yes. Oh. Okay. It sure is. Yeah, I'm not a white person. All right, so the most common example would be the anorectic cat in the hospital. Fat cat stops eating. The body says, oh no, I'm starving, I need nutrition. Good thing I've got all this fat here. It metabolizes all of it real fast and it clogs the liver because liver fat is building up in your liver cells because there's more coming in, right? The liver is not necessarily diseased, it's normal, it can handle lipid, there's just too much at once and it's like, I literally can't even. In some species, lipidosis of tissues is considered normal, either anatomic or some kind of seasonal variation. So if you look at a normal shark liver, it's like super pale yellow. And that's normal because they store fat in their liver. Cat kidneys, you'll notice cat kidneys are also always look a little bit more yellow than other species kidneys. That's because they have tubular lipidosis, so like they have lipid in their renal tube themselves. Lipid in tissue is always going to give the yellow color when it's there in large amounts. So an organ that is affected by lipidosis is going to be enlarged. We've added something to the organ, we're adding lipid. The organ's going to be bigger. It's going to be softer. Remember, friable is our fun $10 pathology word for soft. Means when I pick up the liver, usually a normal liver, I can pick it up. I can, be kind of rough with it and it'll stay intact. It won't fracture or break. These livers with lipidosis, I go to pick them up and like my fingers go through them and they can start crumbling in my hand. That's friable. There's going to be a greasy texture. So you'll look at your hands and there will be like an oil slick on your hands. Pretty gross. Again, the color is pale yellow. On histo, so when we look at these under the microscope, we're thinking about lipid accumulating in cytoplasm. Cytoplasm is mostly water-based. You are mostly water-based. So we're going to get a lipid-water interface, and it's going to be a very sharp, well-demarcated bubble of lipid, because it's where oil is in water. So here's what that looks like in cells. And grossly, we have, this is a normal, the entire organ. This liver is diffusely enlarged, soft, and pale yellow orange with a greasy texture. That would be how I would describe this liver. And then on histo, again, the lipid vacuoles inside of cells are very well demarcated because it's lipid meeting water. Carbs can also accumulate carbohydrates in excess in your cells. So glycogenosis, too much glycogen in your cells. Again, this can be physiologic or pathologic. In young animals, it's highly physiologic. So young animals are not as good as at regulating their blood glucose, so they store more glycogen in their liver, and that's normal. Animals with diabetes, so anyone who has abnormal glucose or glycogen metabolism can cause excess storage of carbohydrates in usually your liver cells, sometimes your kidney. So that would be like with diabetes. We have too much glucose in the body. So glucose handling and metabolism are affected, and that's causal substance to pull up. You can also get this with corticosteroid excess, so either Cushing's disease, which is hyperadrenocorticism, hyper, too much, adrenal, corticism, cortical. So too much adrenal cortex. Those are the hormones coming out of the adrenal cortex. That's kind of how we break down words like that. Everybody know iatrogenic? That means y'all did it. So y'all gave too many steroids, you gave a dog iatrogenic Cushing's. You will have a liver that is full of carbohydrates because that causes changes in glucose and glycogen. Grossly, it's going to look very similar to lipidosis. It's going to be enlarged and pale. It won't be yellow and it won't be greasy. It might be soft. On histo, you can differentiate this because swollen hepatocytes, this is water soluble. Glycogen is water soluble, so it's a water soluble thing in water. It's not going to have sharp vacuoles. It's just going to look kind of like fluffy stuff in the cytoplasm, or lacy. Some people say the cytoplasm is lacy, like this. So up here, up top, this is lipid, nice sharp borders. Here, I can't really pick out any individual vacuoles. The cytoplasm just looks pale and kind of lacy or fluffy compared to which I realize now that I haven't showed you what a normal hepatocyte looks like. That's on me. Okay, so here's a glycogen liver. I would describe this liver as the liver is diffusely, moderately enlarged with rounded edges. The liver is soft. I can tell that because it's cracking. So the liver has a friable texture. It also has, remember we talked about that enhanced reticular pattern, so I can see the outlines of the liver lobules when I should not be able to. So there's some kind of hepatopathy going on here. In this case, it's glycogen. So glycogen liver, big and pale, but not greasy and yellow. Lipid liver, big and pale, greasy and yellow. Both friable, both big, swollen, pale organs. Other carbs, don't worry about these diseases until next year. So there's a large group of enzyme deficiencies resulting in these lysosomal storage diseases, which are genetic diseases that occur in many different species, including humans. There's a lot of different types because there are a lot of different enzymes that can be affected. Big picture for you guys, we lack the enzyme that breaks down a normal product. We cannot break down that product. Product accumulates in cell. Eventually, it's going to accumulate to a degree that it causes dysfunction in the cell and potentially death. That's lysosomal storage. Don't worry about any of the names of these. All right, protein. We can also accumulate protein in cells. I've outlined kind of 3 different scenarios for how that can happen, and this is I forget what I was going to say there. Strike that sentence from the record, please. So you can have too much being produced or more being produced than is being metabolized. So either I'm making too much or I'm metabolizing it too slowly and it's building up. So some example of these, have y'all met Dr. Russell yet? He's another pathologist. You'll have him a lot next year, but he did not name these. Unfortunately, there's probably some human MD, PhDs trying to name stuff up for themselves always. But Russell bodies are immunoglobulins, so antibodies that are building up in constipated plasma cells. So this guy is a constipated plasma cell right here. It's called a Mott cell. And all these little bubbles in the cytoplasm are just wads of antibody. This guy has been working so hard to make antibodies. He's now all of them. We're making too much. You can also see with sometimes renal disease, you can get resorption droplets. So droplets of protein in your renal tubules that are being absorbed from the urine. Usually if you have glomerular disease and you're leaking protein into the urine, the tubules will try to resorb that. So you can see little protein inclusions in kidneys. So those are all pretty much normal host proteins that are just in excess or accumulating. You can also have abnormal proteins, so exogenous proteins. The classic for this would be viral inclusion bodies. So these are viral proteins that the virus is using the host cell to produce its proteins. This is an abnormal protein that the cell has never seen before. We have no mechanism to degrade it. It accumulates, and we can see those in cells. So this image down here is a crazy disease. You've probably never seen it. I've never seen it in real life. It's called molluscum contagiosum. It is a pox virus. Pox viruses are one of the ones that are notorious for causing really big, crazy inclusions. So what we're looking at here is epidermis, this is skin. And all of these giant pink balls are huge viral inclusions. Everywhere you see a giant pink thing, that is Chancellor virus. You can also get defective protein folding. So maybe the substance is normal, but it has an abnormal conformation and we can no longer break it down. So prion diseases, another example of this. Any questions so far? Yeah. Amyloid. This is a big class of proteins. It is not one specific protein. It refers to a protein that is folded in a specific way. You guys remember this? You all have like biochemistry, biophysics, alpha sheets, beta sheets, and alpha helices. It's been a long time since biochemistry, and I didn't love it. So alpha Helices are easy for the body to break down. Beta sheets are not easy for the body to break down. So when we have a normal host protein that goes from an alpha to a beta, we then have trouble digesting it. So this is a big family of proteins that form aggregates because the body can't really digest them. There's a lot of different forms. They're distinct chemically, so they're coming from different places. They're produced by different areas of the body, but microscopically and functionally, these are all very similar. So we kind of lump them. And essentially the pathogenesis of what's going on is this substance is building up outside of cells. So most of the stuff we've talked about has been building up inside of cells. This is actually building up outside of cells, and it's causing what we call a space occupying lesion. So space occupying lesion is anything that separates cells from their blood supply, right? In this case, it's small. I'm inserting things between cells, and we're just kind of gradually increasing the distance between them and their nutrient supply. And eventually they're just like, I can't deal with these conditions anymore. It's like workers during COVID. They're like, I'm out. No, it's not me anymore. You can also have grossly appreciable space occupying lesions. So like a tumor is a space occupying lesion. It can cause, large scale compression of organs, compromise of those organs. So space occupying effects are just damage from something taking up space, even if it's something inert like amyloid. All right, there are two major types of amyloid, and then there's a small handful of minor types of amyloid. For you guys, for sure, 100% know these two big types. Don't worry about the other miscellaneous types. That's path stuff. So AL amyloid, the L stands for light chains, because these are the light chains of antibodies. And the reason they are building up is because they are being produced in excess by a neoplastic population of plasma cells. So AL amyloid is most common in humans who get plasma cell tumors. Some people also call this primary amyloidosis, as in it's a primary disease. The disease process is these neoplastic plasma cells. Because they're neoplastic, they are monoclonal, which means mono, one clonal clone. So it's like the same plasma cell has just made 1 million copies of itself, and they are all making the exact same antibody. So it's not like your normal antibody response where you've got a bunch of different levels. This is you're making one antibody over and over, and it's starting to accumulate places. So again, these are secreted in the blood. There's enough of them, they start to kind of gum things up. They precipitate out of your blood into your tissues, into your capillaries, especially the glomeruli in your kidneys. So they clog up your glomeruli and they cause renal disease. It's a pretty common outcome. Fragments of these are also detectable in urine. So when we see these immunoglobulin light chains in urine, we call them Bence-Jones proteins, and that's considered diagnostic for plasma cell neoplasm of myeloma. That's AL amyloid. It's most common in human beings. It is less common in animals.
So I guess how would you detect them on a machine? Because it won't show up on your analysis.
Plasma phoresis, like a gel electrophoresis. Like I think it's plasma phoresis, and it's not urophoresis. Yeah.
Why don't you leave the blood? But if
Urine's fair game.
Okay.
Yep. All other fluids are acceptable. Great question. All right, AA amyloid. This is the big one because this is the one we see all the time in animals. It is super common. Less common in humans, more common in animals. This is also called secondary or reactive systemic amyloidosis because it is not really a primary disease. It is secondary to another primary disease. The disease it's going to be secondary to is chronic inflammation. Anywhere, anytime, anything that causes chronic inflammation in your body. So when we have inflammation, we're going to learn about this in a couple weeks. Don't worry about it too much right now. But you start to produce a series of proteins that are associated with inflammation. They're called acute phase proteins, happen in acute inflammation. One of these is called serum amyloid A. So this is a good thing. It participates in the inflammatory response acutely, but its purpose is to spike up. The body deals with the acute inflammation and then it's supposed to go away. We're supposed to come out of inflammation and go back to homeostasis. If we stay elevated, this bad boy is gonna start precipitating. It's gonna start misfolding, precipitating in tissues and causing problems. So we get amyloidosis in animals usually when we have chronic inflammatory diseases. Chronic inflammation, chronically elevated serum amyloid A, which is, the name kind of tells you this is an acute phase protein. It's supposed to be acute, short duration. It's not supposed to be chronic.
Oh, I was just wondering, so is this what you're testing for when you're doing like an SAA kit? And then you're testing like how severe the infection is, these sort of numbers, like?
So that's a little, it's similar but different. You're not looking for amyloidosis. You're looking for, is there acute inflammation?
Okay.
This is a marker of acute inflammation. It is supposed to be elevated in acute inflammation. That's normal. It is not supposed to stay elevated.
Okay.
Stays elevated, danger, precipitation, amyloidosis, death. My table. Okay. Amyloidosis can go everywhere. I've seen it in all kinds of crazy places in the body, especially in primates. It especially loves the liver, kidney. Also spleen, intestine. I've seen it in thyroid. It can go anywhere, do anything. The nasal submucosa in horses, species that are affected, primates and avians do this disease like it's their job, like all the time. Mice also, rodents get it a lot. But you can see this in any animal species and it's relatively common. Okay, everybody understand amyloid, primary, secondary? Pause for questions because this is a big important one. Yeah.
So if you have chronic inflammation, your body's gonna make a bunch of amyloid and it precipitates.
It makes SAA in the alpha form.
Okay. And then it is gonna precipitate onto an organ or multiple organs.
Huh?
Once it's precipitated onto the organ, is that, can you test, is that just a finding that you see in, you do the necropsy?
Mhm.
But if you were to like say pull blood or however you would test for it, normally,
I don't believe there is currently a test for amyloid, like a biomarker in the blood for amyloid. It's biopsy, histopathology. Yeah, unless anybody knows differently.
How does amyloid look grossly?
My slide says pancreatic islets in cats, that's
Yeah.
supposed to, okay.
Yeah.
So you see them build up there too.
Okay, we haven't done this slide yet, don't ask me about it.
It was on that slide. It is on that slide.
yeah.
This
It's
slide,
on ours.
Yeah.
that's not supposed to be, I didn't put it there.
So you put the AL is common in humans, but AA is common in primates.
Animals, especially primates, birds, rodents. All my favorite species.
But not including here for primates.
Oh, no, humans, no,
Okay.
non-human primates.
Okay, cool.
Because humans deal with their inflammation, right? We're big babies. As soon as we have chronic inflammation, we try to suppress the hell out of it. Animals were like, nah, you can live with your dental disease for 15 years. Did I get everybody?
I was gonna ask about that image, so that would be a constitution of. Grossly affected organ from amyloid. Okay, and you can tell that. Why?
Well, you can't tell it yet. Cause I'm literally teaching you right now how to tell it. But let's describe it. How would you describe that kidney? The kidney is. Usually start with the distribution. Is it focal, multifocal, diffuse? Diffuse. At least in the cortex. I can't tell if the medulla is affected, the medulla might be normal, but the cortex is definitely diffusely affected. So the cortex is diffusely. I heard thick, pink,
Yeah.
light pink, orange, it's too pale. It looks like chewed bubble gum, yeah, there's a weird texture to it too, it's not just the color, it's texturally wrong. I can't tell because we're on the wrong side. Right, I can't see the vessels, it could be a small dog. Waxy, that's the amyloid descriptor for this texture, it's pale, waxy, firm. Grapefruit colored? I like chewed bubble gum, because that gets kind of the color and the texture. Another thing I would say about this kidney, the corticomedullary junction is indistinct. We're playing spot the difference between this and a normal kidney. Normal kidney has a sharp line between cortex and medulla. I'm having trouble here, it's like right here, but it's kind of fuzzy. This kidney, this is a little bit more subtle, so these are now like pro level, spot the difference. This kidney is enlarged. And I can tell that because the kidney has a capsule. It's this little white line right here. And see this little shiny, I can tell by the contours here that when we cut into this kidney, it bulged a little bit from under the capsule. It's too big, it's swelling inside the capsule. We don't have rounded edges because it's a kidney, it's always round. Rounded edges for the liver, bulging from the capsular surface for kidneys. Okay, there are other types of amyloid. You can get this as a genetic disease. You are genetically forming misfolded proteins, and they accumulate. This is much more common in humans. When we think of it in animals, we think of it with these specific breeds. Islet amyloid or IAPP, this is a protein that's produced in the pancreatic islets of cats. So remember, this is accumulating extracellularly. Accumulations usually are occurring at the site of production. So amyloid here is gonna accumulate in the pancreatic islets. It's a space occupying lesion. It's gonna separate islet cells from their blood supply. They're gonna degenerate and die, and this animal is gonna get diabetes. So islet amyloid in cats can cause diabetes. So that brings up an interesting point about amyloid. The disease or the clinical presentation or the signs that you're gonna see are gonna be related not necessarily to the amyloid itself, but to the organ that's involved. So if you have primary renal amyloidosis, your presentation is going to be very different than if you have primary hepatic or intestinal amyloidosis, right? So the presentation of amyloid is quite broad because it depends where it's going. Usually liver, kidney, can be a lot of other places, so it can present a lot of different ways. And then beta amyloid, so this is kind of the brain amyloid, I remember beta, right? So this is like the amyloid of Alzheimer's, or we found similar proteins in the brains of old dogs, so it's like dog Alzheimer's, maybe canine cognitive dysfunction, kind of similar. But again, these are just abnormal misfolded proteins that are accumulating extracellularly and causing dysfunction in tissues. That's Alzheimer's, right? All right, so more important for you guys, what does amyloid look like? Let's do gross first. The affected tissue is going to be swollen, so it's going to be enlarged. We're adding something to the tissue, so it's getting bigger. It's going to be firm, so that's going to help you distinguish from lipid and carbohydrate. Those are going to make the tissue more soft. Amyloid is going to make the tissue more firm. It's going to make it waxy and pale, like thus. So these are all liver, and here's a little cross-section of kidney. I have no idea what that little blip is. Here is an enlarged liver. Look how round the edges are. That is a big boy. I don't even need the ribs to tell. Too big. It also looks, feeling it with my eyes, this comes with experience, it looks very firm to me. There aren't any cracks on the surface that would tell me there's one right there. That looks more like a cut, maybe. And this is, I would say this lesion is diffuse. Liver is diffusely, severely enlarged. About 50% of the organ is this kind of pale tan, yellow, orange color, and the rest is kind of a, dark orange, red, like old ketchup kind of type lesion. And I would say on cut surface, the liver has a homogeneous texture. It all looks like this inside. Like this. You can see kind of the orange coming through. This one is much more orange. This one has an enhanced reticular pattern. See that little lines? Kidney also similar to that other kidney. It's enlarged. It's got kind of an orangey color. So your big differential here is going to be lipid, a big orange organ. If it's soft and friable, it's lipid. If it's firm and waxy, it's amyloid. Don't really worry about what it looks like on histo too much right now. But here's the facts. Again, it's extracellular. That's probably the most important. So it's space occupying. It's going to squish things. It's going to separate them from our blood supply. It is going to cause death of cells wherever it starts depositing. For confirmation, we use something called a Congo red stain that actually highlights the amyloid, so we can see, is this amyloid? This stuff right here, this could be collagen. So when we see it on histo, a lot of times that's our differential. Is this just scar tissue or is it amyloid? So we throw special stains on it, and it helps us decide what that stuff is. Here's Congo red. So this is a kidney. We're looking at the glomerular tufts, and we're highlighting amyloid pink. It also fluoresces apple green under polarized light.